Hi, everyone. Thank you so much for staying till so late. You can feel free to get up and move around a little if you want to. I would not mind. I also just want to thank the CFAR so much for taking a risk on me. And as a pharmacist, it's really not a typical role to do behavioral and clinical research. So I really appreciate it because, as you'll see, both of the two awards that I received from CFAR have resulted in the biggest part of my career. Essentially, my research is focused on HIV prevention and treatment and how we can modify current models of care and make them work better to fit the needs of patients and also research participants. So technology has a big role in all of my research projects because it always seems to me there's so much that we can automate, delegate, or just conduct remotely. So that's a big theme that's going to come up in a lot of these projects. So I don't have a lot of background because I feel like I'm speaking to the choir, so I don't think there's any reason to go into details of why PrEP is important. But one of the first CFAR awards that I received was under the mentorship of Dr. Monica Gandhi, and it was around creating a mobile health tool for PrEP to help prescribers. So one of my biggest frustrations at the time was that a lot of researchers were really focused on adherence of the patient, and really for me it seemed like the bottleneck was the providers getting on board and really having first of all the knowledge of prescribing PrEP, but also feeling comfortable in having conversations with patients and then doing proper monitoring and follow-up. And it seemed, again, one of those things that could be, it's such a finite body of knowledge that it could very easily be automated and to make it more efficient. So the idea was that we could create a tool, and I called it PrEP-RX, just because I had to have an RX because I'm a pharmacist, and it would basically help to educate providers regarding PrEP, provide them assistance and guidance in identifying who are appropriate patients to start on PrEP, and then providing proper monitoring and follow-up ongoing. And then I had a small pilot study that I did at Ward 86 using this tool. And we had a publication, and the outcome was an R1 from an INR regarding this intervention. So basically, it became very clear to me that providers actually don't want to be involved, and we really need just another person, i.e. PrEP coordinator, to do most of this work. And it really makes sense to do that because most of I would say 95% of work related to PrEP doesn't require a medical degree, and with all due respect for everyone here who has a medical degree, most of the things besides signing off on a prescription, which is required by law, and then if any there's any clinical need later on after the person gets started on PrEP, so side effects, need for changing in medications, changing in dose, that's when the medical degree is needed. So essentially, we created the PrEP optimization intervention that was targeted at healthcare providers to try to increase PrEP uptake and persistence. And it included a PrEP coordinator who would basically do everything PrEP related. So assessing risk, sending all the labs, even writing the prescription so that the provider could sign off on it. And then once a patient started on PrEP, they would do all the monitoring and follow-up thereafter and really bring the provider in if it was really medically necessary. And then we used the tool that we created, PrEP-RX, to help make the work of the PrEP coordinators more efficient. So PrEP-RX gave this, we have this really comprehensive risk assessment tool that the PrEP coordinators can use and actually just hand the tool over to the patient to do, and it gives reminders for monitoring and follow-up, and I'll show you what it looks like. So the primary aims of this study was to increase PrEP prescriptions, and we have 10 clinical sites. It's actually 14 clinics, but some of them are bunched together because they're all part of the children's, the CHIPPY clinics. And the idea was that the intervention would actually target all the steps of the PrEP cascade, so from increasing awareness to retention in care. So we did this via a stepped-wedge design, where we had this pre-randomization phase where we just examined what the clinics were doing and monitored their PrEP use. And then we had the stepped-wedge phase where the 10 clinical sites, one by one, got randomized and started on PrEP. We're actually in the middle of the stepped-wedge phase. And then the next phase is a follow-up phase where for 12 months we just observe with the intervention how the clinics do. So this is a hypothetical clinical flow that we hypothesize for clinics. So the patient would be referred to the clinical, the PrEP coordinator, either via the provider, a self-referral, or through an STI registry. The PrEP coordinator would, during that first visit, would enter the patient's information into the Salesforce database, which is PrEPRx that we created. They would assess insurance coverage, order labs, discuss PrEP use, and then the patient completes this, the risk assessment on this tablet. The patient's labs get integrated into the Salesforce backend. I would say, unfortunately, and a little embarrassingly for San Francisco, we still haven't figured out data integration because of ECW, and hopefully once we get EPIC, this will be solved. And then the provider at that point can basically, through PrEPRx, can review their dashboard, and they can look at the risk assessment, the labs, the PrEP timeline, and then sign off on the prescription if it seems reasonable. And then from there, the PrEP coordinator takes over. They do a 1-week follow-up just to make sure the patient picked up their meds, they're not having any side effects, and then the 1 month and then quarterly follow-up for adherence, and then labs. So these are the clinics that we have so far. So again, Ward 86 was our pilot study, so they're not part of this study. Right now, we are about to onboard Maxine Hall, the 3 remaining clinics will be started in the next few months, which is a little scary because EPIC is about to start as well. So we're really nervous about that. And we got the website, prep.ucsf.edu, so we're really happy about that. And Dr. Monica Gandhi's her lovely face is on our website. And the PrEPRx login is directly on the site, so providers can go there and through the single sign-on from My Access or via another mechanism. If they don't have My Access, they can log in. And so this is basically what the tool looks like from the PrEP coordinator's perspective. So they basically enter in all the patient's demographic information, contact info. There's a risk information. There's and I'm going to show you this, the patient consultation responses and checklist. It's basically a checklist to remember what they need to go over with the patients, and then the follow-up consultation. And there is a timeline that's created here where the PrEP coordinator gets, just going on its own. The PrEP coordinator gets reminders about what they need to do next for the patient, and they get emails to remember to call the patient for any upcoming events. This is the checklist. So again, the PrEP coordinator will be reminded to ask about, ask the patients what they're hoping PrEP will do for them, what questions they have about PrEP, and then to make sure that they go over a various list of consultation points about indication, dosing, adherence, side effects, so on and so forth. This is what the provider view looks like, and the provider view looks different because, frankly, most of the providers told us they want a read-only version. They don't want to have anything to do with making modifications. So the provider basically gets a list of all their patients that are on PrEP. There's a quick reference for the risk, any missed activities with the date, and then their next appointment, and then they can drill down further by clicking on view details, and this is what they see. It's 4 different boxes. The first box shows demographics. Bottom left box shows the current timeline, so where is the patient in their PrEP journey, and it also shows if the patient's been on and off PrEP multiple times and what the reasons for that is. And then there's the risk box where there's a quick referral on risk for IDU, MSM, and heterosexual risk. If they click on high or whatever is in blue, they get a list of exactly the reasons the patients indicated for being at high risk, and they can drill down further if they want to look at the entire survey. And then we have these alerts, like the patient reports acute HIV symptoms, so things that aren't necessarily in the risk, but the provider needs to be alerted of. Actually, I forgot to say that there's a box underneath here that's not shown, and that's where the lab integration, when, inshallah, once it occurs, it'll be there. So I don't have a lot of results from the intervention, but I thought that I wanted to share some results about the providers, because we do some demographic, we collect some demographic data right at the beginning of the study, so I thought these were somewhat interesting. So most providers were female, Asian or white, and mainly physicians. So these are all prescribing providers, and they had a panel size of about 391 patients. So 81% said they had ever prescribed PrEP, so there's 42 individuals. 33% said they had ever referred for PrEP, their patients for PrEP, and the number of patients in the providers' panels, the median was 1 on PrEP, which I thought was really, really low. And then their willingness to prescribe to adolescents, so 13 to 17-year-olds, was only 62% said that they were willing to prescribe to adolescents. We asked them, in your practice, who currently provides the following types of PrEP services. The blue is that the provider does, and orange is the nurse. So as you can see, the blue and orange is the majority of both of all of these, so adherence counseling, labs, tests and monitoring, and risk reduction counseling. And that's partially why we're doing the study, to try to move some of this burden from the providers to the PrEP coordinator in gray. So hopefully we'll see a shift in that, but interesting that there's so much of this burden is on the providers. So we also asked them, in the past year, how often have you done any of the following tasks? So starting out with offering HIV testing to patients who are engaged in high-risk behavior. So the blue and the orange is mainly the 2 bars to look at, which is always and often, and this becomes less and less. So asked about sexual partners, less than that, offering HIV testing to those who don't obviously have a risk. Asking about sex partners becomes a little less. Asking about sexual partners, HIV status, and then initiating conversation about PrEP is pretty low. So interesting data. And then I'm confident that I or someone in my clinic can do any of the following tasks. So identify individuals at risk for HIV infection. Sounds like it was pretty good. And then providing risk reduction medication adherence counseling, providing HIV testing every 3 months, and then follow up every 3 months to monitor side effects for PrEP was much less. And this is actually kind of surprising to me, because the data that we are collecting from the clinics shows that this is a lot less than the providers actually thought was happening in their clinics. So the future direction for this project, again, born out of the little seedling of our CFAR grant, is basically to refine PrEP-RX. So we're doing that this year to create version 3.0, because we have a lot of feedback from the PrEP coordinators now. We're completing the stepped-wedge phase of the study this year, and then the follow-up phase will be completed next year. We have data on the patient, provider, and clinic level, so I think that would be really interesting to look at all these 3 levels. This is kind of an ongoing struggle for me, is the sustainability of the study and how we can fund ongoing PrEP coordination support. So if anyone has any brilliant ideas, please let me know. And then I'm personally more interested also in identifying other comorbidities, like hepatitis C, for example, that a similar model could be applied to, and then examining this model in other areas that are less, that have less resources. So I'm going to move on to the second CFAR Award. So this award was called Social Networking Technologies in Improving Treatment Engagement of Young Black HIV-Positive Individuals, and Dr. Mallory Johnson was my mentor on that. Through this, we wanted to examine the feasibility and acceptability of social networking technologies and video conferencing for medication counseling. So this was also I felt like one of my frustrations that, within clinics, a lot of patients would miss their appointments, particularly with the mental health provider, the pharmacist, and it would be really hard for them to be able to reschedule another appointment. And this happened a lot with the younger population. And again, I think Al did a really great job in identifying why that's important to be able to provide these services for the younger individuals living with HIV. And so the idea was to figure out other options in trying to provide services. Again, this was resulted in a publication and a CHRP award. And so the idea of the CHRP award is to examine the feasibility, acceptability of interventions delivered by technology-based methods for decreasing substance use, improving mental health, and enhancing engagement in HIV care among 18 to 29-year-olds living with HIV. And so far, we've completed a lot of formative research on this to talk to providers of youth living with HIV, and then conducting quantitative and qualitative research with the target population. We created this youth advisory panel to really help us, examine the feedback that we were getting from the research and disseminating our results. And then we created this intervention called Y2 Tech. So it's youth to telehealth or text message to improve engagement and care. So we are in the middle of this pilot RCT that we finished recruiting for just 2 months ago. And we advertise on Facebook, Instagram, Grindr, and we had participant referrals and also asked providers to refer their patients. And I'm not going to go into the detail of this, but essentially it's this 2-arm study. We workshopped these names heavily, Rose Gold and Jet Black. So Rose Gold gets the intervention immediately after they are consented, and then they have 11 sessions once weekly by Zoom. Jet Black basically doesn't, only gets text messages until 4 months, and then they start their Zoom sessions with a counselor, so they get 12 sessions with a counselor via Zoom on a weekly basis. And the intervention is based on the IMB, Information, Motivation, Behavioral Skills Model, and motivational interviewing. And based on the acuity of the patient or the participant from the first survey, they get between 3 to 6 sessions on HIV, psychoeducation, mental health, and substance use. And then the remainder of the sessions are really these menu options that the participant gets to decide. So anywhere from social support, family, sexual relationships, disclosure, or anything that they want to talk about, they get to decide. And this is a remote research, so the first visit is done in person. From then on, incentive is via a Clin card, so it's a reloadable debit card. Mozio is a text messaging platform that we're using. Zoom is for video chats. Qualtrics is for assessments, and this new technology called the telephone we're using for qualitative exit interviews. And as most of you who work at UCSF know the Zoom experience, but these are my research coordinators who were playing around with it to create a picture. But basically what we were able to do with Zoom is create these virtual waiting rooms. So the participant comes into the waiting room, but they actually can't join the meeting until the counselor allows them to join the meeting. So it's similar to an actual counseling session. And then, so far we have 50 participants, so 25 in each arm. And we've had now over 463 sessions, and 90% of those have been completed on time or rescheduled to be done on time. And for those of you who work with this population, you would know that 90% is pretty high to establish with this population. So that's been a win for us already. And 100% agreement or strongly agreement on the fact that the sessions have been right for them and they felt heard, understood, and respected by the counselor. the mean length of sessions is 26 minutes, and that's been really important for us. We really wanted to keep it short because it's really hard to, keep someone's attention for that long on Zoom. So 26 minutes is the mean. Audio and video quality has been a little spotty, so 8.6 to 8.3 out of 10, and 52 disconnections. Again, I don't have the final results for the study, but our participants have been, on average, 25 years of age, mainly African American or multiracial, male sex and gender, and mainly identify as gay. What's been interesting is that we kind of knew that things for variables for mental health and substance use would be quite remarkable. So, for example, about two-thirds or 80% of the participants reported either having mild, minimal to severe depression. About 18% had a likely diagnosis of PTSD, and some pretty high levels of alcohol and substance use. What we weren't expecting is that on ACEs, so ACEs is Adverse Childhood Experiences questionnaire, which basically asks, when, before I turned 18, or before you turned 18, did you live in a household, for example, if that someone insulted you or beat you, or someone in your household struggled with alcoholism or went to prison? And the 4 cutoff is kind of what's used in a lot of research to show differences in outcomes, and 90% of our participants had greater than 4 on ACEs, which I thought was startling. The other one was on PSQI, so this is a questionnaire for sleep quality, and close to 70% had indications of poor sleep quality. Again, things that I wasn't expecting, so interesting to examine those further. So I have some lessons learned. So for our recruitment and enrollment, we use Grindr, and if anyone wants to use Grindr, please come and talk to me so I can talk you out of it. It actually was not a very good experience. I've used them twice. The first time was fantastic, and the second time they had to change their model, and it's not working. So we ended up spending a lot of money, and they didn't come through. Another thing was the role of participant referral. We increased our participant referral fee from $10 to $30 for both the referred and the referee, and we got 0 people referred, and all of our participants said they don't know another young person living with HIV, which really went to show the social isolation in this population and really the importance of research. We had a request for doing an in-person enrollment for the very first visit during our formative research, and that's why we do our first session in person for the intervention arm. However, this actually ended up not being good for the research because a lot of participants didn't want to come in and they wanted to do the entire thing remotely. So it was one of those things that we ended up missing out on many individuals because of the ability to bring them in for the first session. So the counseling sessions, the session locations has been a challenge. A lot of participants have called us as they're in their car crossing the Bay Bridge, and there was a lot of education that's needed to go into making sure that the person is safe where they're at. As most of you know, with Zoom, there's always Wi-Fi and reception issues, so this has impacted flow and rapport for some of the participants. And also consistent access to personal cell phones, and even though this population they all have access to smartphones, we've had people who share phones or lose their phones very frequently, so that's also been a struggle for the study. So as far as future directions, we're completing the pilots in November, and we're going to be able to analyze the data then. We're creating Y2Tech 3.0 protocol so we can apply for further funding to expand the reach of this intervention to either a statewide or a nationwide type study. And with that, these are all the ways to say thank you in Persian. So merci, tashakkur, mamnoon, to CFAR for the various grants, the NINR, CHRP, the study participants and study clinics, and also, of course, my mentors, colleagues, and research coordinators. And I'll take questions.
Questions, Geraldina?
How about I'll go while you get a mic? Hi, Parya. I'm Lisa Lobstanger from CHRP. Two things. One, I really want to compliment you on your choices of outcome measures. I think those were really creative and important, and I think you did a great job of that.
Thank you.
And sure, and my other thought is a comment. I was at a meeting last week with Alameda County folks. Steve Gibson is now at Alameda County, and he sort of put out a call for things that will work to increase access to care, specifically for folks in Alameda County. They have some challenges. There's not an STD clinic. I'm thinking, I don't know if he has funding that would really replicate it, but or to sustain it, but at least he might be willing to replicate in Alameda County. So
Yeah, I would love to.
I'll connect you
I would love
guys.
to do that. Yeah, thank you.
It's really interesting use of technology. I was just wondering, and in the last one when you were creating the sessions for counseling, most of or a lot of the people here have a substance use issue. I'm assuming, I don't know if this is true, they also have smoking. They smoke a lot. So does it include any kind of counseling on smoking cessation?
Yeah, that's a great question. So we actually, we talked a lot about this. So we actually ended up taking, so if they want to bring up smoking as a session that they want to talk about, it's included, but it's not a, so substance use during the sessions, unless they have anything else besides smoking, cigarettes or marijuana, it's not brought up as a major topic. So it's only if they're ready to talk about it is that, so they can choose that as part of the menu options.
Great. Thank you very much.
Yay.